Imagine looking at a clinical room where everything is stationary, but your visual field is violently shifting back and forth. When a clinician evaluates involuntary eye oscillations, the assessment begins with a single question: does the patient actually perceive this motion? This blank visual field represents the experience of many patients with congenital nystagmus. The first rule of thumb is that if a patient's eyes are moving, but they report no such visual symptoms, the condition is almost certainly a benign congenital form of the disorder. In contrast, acquired oscillations develop later in life and are characterized by a specific disorienting sensory experience. This is oscillopsia, the perception that the stationary world is in constant motion. When a patient reports this, the diagnosis immediately shifts toward potentially severe neurological or vestibular pathologies. While congenital forms are self-limited and benign, acquired forms require precise neurolocalization to identify the site of neurological failure. The presence of oscillopsia transforms a simple visual observation into a rigorous neurological investigation, requiring the clinician to systematically peel away layers of clinical signs. This diagram maps the evaluation into 3 specific nodes: the patient's presenting symptoms, the physical signs on examination, and the neuroanatomical failures driving the movement. To categorize these movements, the examiner must observe the eyes in their primary forward position and in lateral gaze, while also testing the effects of convergence and monocular occlusion. Waveform kinematics, the specific physics of how the eye moves, act as a physical readout of a failure within the brain's neural integrators. By correlating the patient's subjective description with these objective kinematic signs, we can localize the site of the circuit failure. This checklist outlines the specific questions required to profile acquired oscillopsia. We must determine if the world moves vertically, horizontally, or rotationally, and whether the effect is monocular or binocular. Identifying precipitating factors is equally important. Is the oscillation constant, or triggered by head movement, or specific body positions, like lying on one side? If the motion is only triggered when the patient gazes away from the primary position, it indicates a different underlying mechanism than oscillations that occur at rest. The patient's awareness of the eye movement itself, specifically how they experience it and when it began, provides further evidence for localization. Asking a patient to use their hand to demonstrate the direction of the world's movement provides a tangible measurement of the vestibular or central mismatch. A thorough patient history often narrows the diagnostic possibilities to a few specific neural circuits before the physical examination even begins. This graph plots eye position over time to distinguish between pendular oscillations, which are smooth and sinusoidal, and jerk nystagmus, which follows a sawtooth pattern. In jerk nystagmus, the slow phase, the velocity of the eye as it drifts away from the target, provides the data necessary for localization. A perfectly linear slow phase indicates a tonic imbalance, typically arising from a defect in the vestibular system. When we see a decreasing velocity slow phase, the eyes are drifting back centrally because the nervous system is failing to produce a step command to hold the gaze. These decreasing velocity waves are characteristic of cerebellar, brainstem, or cortical lesions, and they are also observed in latent nystagmus. Conversely, an increasing velocity slow phase identifies an unstable neural integrator. If the movement is primarily horizontal, it is a hallmark of congenital nystagmus. The specific geometry of the slow phase slope is the physical proof of which component in the brain's control system has failed. These movements are mapped using the pulse step model. The PPRF generates the high-velocity burst of innervation to move the eye, while the integrator provides the steady step required to hold that new position. In internuclear ophthalmoplegia, the MLF pathway is damaged. When looking toward the side of the lesion, the contralateral eye cannot adduct, while the ipsilateral eye exhibits a distinct gaze-evoked nystagmus. Paranod syndrome, or dorsal midbrain syndrome, involves failures in upgaze and is often accompanied by convergence retraction nystagmus. Lesions in the rim MLF can cause a selective loss of downward saccades, even while the downward vestibulo-ocular reflex remains fully functional. Ultimately, every specific wiggle observed on examination points to a compromised pathway within the brain's complex oculomotor circuitry. This graphic shows the hierarchy of the diagnostic flow. We move from the patient's subjective symptoms to objective waveform kinematics, and finally to neuroanatomical localization. A valid diagnosis requires that the patient's description of their world's motion is physically consistent with the eye movements observed by the clinician. Management focuses on identifying the underlying neurological threats and mitigating the debilitating effects of oscillopsia. For the wiggly-eyed patient, the objective is not just to stop the movement, but to decode the diagnostic signal to ensure the patient's long-term neurological health.